I'm going to be presenting, attempting to answer the October 2022 practice question 4B. This is the question. A 23-year-old PLWHA presents with skin lesion in the picture, in bracket, voluptuous nodular lesions on the face. Describe the lesion. A, what is the diagnosis? B, what is the cause? D, what are the 4 types or classes? E, the histology finding in this condition. List 3 differential diagnoses. Mention the treatment options for the disease. And lastly, what factors will determine the prognosis? Okay, thank you. I was able to get this picture from a colleague that sat for the exams. A, describe the lesion. So I attempted describing the lesion as a picture of a male with discrete voluptuous papules and nodules on the face, extending from the hairline to the posterior part of the ear, the beard area, and the neck of the left side. Next slide. What is the diagnosis? The diagnosis is Kaposi sarcoma. C, what is the cause? It is caused by an infection with human herpes virus type 8, also known as Kaposi sarcoma-associated herpes virus. HHV8 is identified as the causative agent of Kaposi sarcoma. It is present in 95 to 98% of all cases. Next slide. What are the 4 types? We have the epidemic or the AIDS-associated type. We have the iatrogenic or immunosuppressant therapy related. 3, classic or sporadic. And E, endemic African type. The epidemic or AIDS-associated Kaposi sarcoma occurs in patients with advanced HIV infection and is the most common presentation of Kaposi sarcoma. It's an AIDS-defining cancer associated with decrease in CD4 count and increased HIV viral load are independent prognostic factors in the development of epidemic Kaposi sarcoma. Immunosuppression-related Kaposi sarcoma can occur following solid organ transplantation or in patients receiving immunosuppressive therapy for other indications. Disease regression is frequently seen with reduction or withdrawal of immunosuppressive therapy. Next one. The classic or sporadic Kaposi sarcoma typically occurs primarily in elderly men of Mediterranean and Eastern European background. It has a male predominance with a male to female ratio of 10 to 15:1. The age of onset is between 50 and 70 years. Classic Kaposi sarcoma usually follows a protracted and indolent course. This form of the disease rarely includes lymph node, mucous membrane, or visceral involvement. The endemic. This entity occurs primarily in male, but also in women and children in sub-Saharan Africa who are HIV seronegative. It may have an indolent or aggressive cause, extensive skin infiltration, especially on the lower limbs, high rates of HHV8 infection in the general population in this part of Africa. E. What is the histologic finding in Kaposi sarcoma include the following: proliferation of spindle cells and endothelial cells, extravasated red blood cells, hemosiderin-laden macrophages, and in early cases, an inflammatory cell infiltrate. Next slide. Pathogenesis is multifactorial. Kaposi sarcoma may be caused by HSV virus with stimulation by autocrine and paracrine growth factors secreted by the spindle cells themselves, as well as the supporting network of mononuclear endothelial cells. Co-infection with HIV may create a more aggressive cause. The spindle cells proliferate in background of reticular fibers, collagen, and mononuclear cells, including macrophages, lymphocytes, and plasma cells. They tend to be vascular, involving either the reticular dermis, which is called the patch stage, or the entire thickness of the dermis, we call the plague or nodular stage. Differential diagnosis. 1. Thought of bacillary angiomatosis. This is often difficult to distinguish clinically from Kaposi sarcoma. It is caused by the Rhododendron species, that is Botaniella species. The lesion typically possesses capillary proliferation and neutrophilic inflammation, in contrast to Kaposi sarcoma lesion, which displays slit-like vascular spaces containing lymphoplasmacytic infiltrates. Both the Kaposi sarcoma associated virus and the Botaniella species, they have predilection for the red blood cells, endothelial cells, and macrophages. So that's why it's difficult to, and both of them called cutaneous angioproliferation. So it's difficult to distinguish it clinically. That's my first differential diagnosis. A skin biopsy of suspected lesion is therefore required to establish the diagnosis, able to differentiate these two conditions. Another one is melanocytes, a malignant tumor of melanocytic cells. We also have this hyperpigmentation, this scale variation that may confuse somebody with Kaposi sarcoma. Hemangioblastima, hemangioma, which is a benign vascular tumor, also can present like Kaposi sarcoma. Other differential diagnosis: pyogenic granuloma, arteriovenous malformations. Then mention the treatment option for the disease. Well, these are the options. The option depends on the number, size, location of tumor, and immune states of the patient. That's the staging of the Kaposi sarcoma. But usually, combined antiretroviral therapy is the first line if treatment is the first line of treatment. But in patients in whom tumor persists or in whom control of HIV replication is not possible, these other following options that I mentioned are going to be used. Antiretroviral therapy is the first line of treatment. It has been shown to cause spontaneous regression of tumor. But in people that have that the tumor did not regress, you can use any of these. If the lesions, but that depends on whether the lesion is disseminated, as they are large, or they involve the viscera, or they are localized, causing significant discomfort or cosmetic problem like the tumors on the face or in the oropharynx, causing difficulty in breathing or swallowing. So this local therapy can be localized radiation therapy can be used, cryotherapy, laser therapy, surgical excision, intralesional vancomycin alkaloid therapy, topical retinoids can be used. But when you have disseminated condition, disseminated diseases, so probably involving the viscera, the pulmonary, and other things, systemic agents can be used. Where you use the alpha, the interferon alpha, as it has been shown to have clinical activity in Kaposi sarcoma. They may be mediated by anti-angiogenic, antiviral, and immunomodulatory properties, but mostly is used in people with higher CD4 count. Next slide. So, but as I said, in disseminated condition where you have large number of tumors or you have visceral involvement, also chemotherapy can be used, in which combination therapy like ABV, atinomycin, bleomycin, vincristine can be used. Single agents also have been, some single agents have been shown to have activity against the Kaposi sarcoma, and this has been shown to be very effective because they have lesser side effect compared to the combination therapy. Things like liposomal daunorubicin, liposomal doxorubicin, and paclitaxel. The liposomal daunorubicin is used as a first-line therapy in advanced Kaposi sarcoma, while the liposomal doxorubicin and the paclitaxel has been shown to be effective in those that have Kaposi sarcoma is that have failed the standard chemotherapy. What factors will determine the prognosis? The major independent prognosis factors are CD4 counts, HIV, viral loads, and the age. But the CD4 count has been shown the most important determinant factor of response to treatment and the development of Kaposi sarcoma. The visceral involvement has worse prognosis is GI bleeding, pulmonary obstruction, cardiac tamponade. Kaposi sarcoma basically affects the skin, the lymph node, the gastrointestinal tract, and the lungs. But however, it has been shown to involve all organs in the body. So in case where they affect the gastrointestinal tract, can affect the mucosa, resulting into bleeding, or can cause intestinal obstruction, and even the pulmonary obstruction, cardiac tamponade if it affects the cardiovascular system. But however, pulmonary involvement is the most common cause of mortality with due to uncontrolled pulmonary hemorrhage. In patients receiving antiretroviral therapy, the disease often has a more indolent clinical course or may regress spontaneously. So as stated earlier on, if they fail to resolve, one can begin to consider other local therapy if the disease is just localized, causing cosmetic problem or significant discomfort as earlier stated. But when they are disseminated, you now begin to look at the systemic agents, chemotherapy either as a single agent or in combination. Thank you for listening.
Thank you so much, Dr. Musa, for that beautiful presentation. And we're right on time. So now we'll take comments and questions from the participants first, and then thereafter our teachers will come in. Okay, so there's an electronic hand up. Dr. Justice, please go ahead.
Good morning, teachers and colleagues. Thank you very much for a wonderful presentation. I just want to add very few add-ons actually. Thank you, it was actually very lucid. Just in case you were asked to talk about, to list the types, there can actually be a fifth type, which is called the non-epidemic Kaposi sarcoma, which occurs in men that have sex with men, but there's no evidence of HIV. In case we're asked to list 5 types. Conventionally, it's 4 types that we know. Then just one more addition. We don't use the conventional staging technique for Kaposi sarcoma because it's difficult to actually measure the size of the tumor. So there's what they call the TIS staging system, where the T is the tumor, if it's which now breaks it down into poor risk or good risk or poor risk. Good risk is tumor confined to the skin. That's T, tumor confined to the skin or lymph nodes, or a minimal non-nodular disease, where you can just get lesion in the palate. I, immune system, that's CD4 greater than 150. Then S, systemic illnesses, as if there's no history of systemic illnesses or no opportunistic infections, no unexplained fever, no weight loss, or weight loss that is greater than less than 10%, or diarrhea not lasting up to 2 weeks. Then the K, they just added, there's a Kanofsky performance status greater than 70. So if all these things are 0, they actually point to low risk. Then into yes, good risk. Then poor risk, T, as there with edema, that's tumor as there with edema, ulceration, extensive Kaposi sarcoma, and like you mentioned, GI Kaposi and non-nodal Kaposi sarcoma, other non-nodal Kaposi sarcoma. I, that's immunity, CD4 less than 150. S, presence of systemic illness. K, cannot scale greater than 70. Then other HIV-related illnesses. So they can actually be called T0, I0, S0, or T1, I1, S1, where it connotes good risk and poor risk. Just little addition. Thank you very much.
Thank you very much.
Thank you so much, Dr. Justice. Okay, I don't know. The one I saw was CD4 greater than 200 and less than 200. I don't know. Maybe I'll check it up again. And it's called the AIDS clinical.
No, the National Institute of Allergy and Infectious Disease AIDS Clinical Trial Group. use the CD4 count of greater than, for the risk, the CD4 count of greater than 200. That is zero,
That's the
stage
one I
0.
know.
And
Okay.
there is the common, there are several staging systems, but the commonest one that people use is the National Institute of Allergy and Infectious Disease, its clinical trial group, where it's staging to stage 0. And with all those things he mentioned, they're there. For the stage 1, CD4 count of less than 200, that's what they used. Anyway, the canostics is still greater than 70 for 0 and less than 70 for stage 1.
Thank you so
Thank you.
much. Okay, Dr. Sani, please go ahead.
Okay, thank you very much, Dr. Gazama, for that presentation. I don't know. Frequently, you have heard that Kaposi sarcoma sometimes can occur, even in patients without depressed CD4 count. It can even be seen in patients with CD4 count of 300, 400, even around 500. So I don't know, based on the discussion, the question that was asked and also the clarification. So can we still entertain that possibility of Kaposi sarcoma? Because if I remember, it's one of the diseases that can occur at any CD4 count, even though it's associated with CD4 count less than 200, but it can be seen at any level of CD4 count, especially with also mycobacterial infection, some of the mycobacterial infections. So I don't know, Dr. Musa, whether you can clarify that statement.
Well, I know that Kaposi sarcoma, a neoplastic, one of the age-defining malignancies in people with viral disease, can occur at any stage of the disease, irrespective of the CD4 count. In fact, paradoxically, even the commencement of the combined antiretroviral therapy can still induce Kaposi sarcoma as the iris, it's a form of iris. So I don't, well, based on the picture, which I just use the pictures to just give an idea. You know, clinically, it's actually difficult to distinguish between the bacillary angiomatosis and the Kaposi sarcoma, as I said, because both the herpes, the Kaposi sarcoma associated herpes virus and the Bartonella species, either the Hensella or the Quintana, they have predilection for red blood cells, macrophages, endothelial cells. They, in fact, induce cutaneous angioproliferation. So clinically, both of them it can be difficult to distinguish unless if you do biopsy of suspected lesion. So, but I chose to take Kaposi sarcoma because it's been seeing that picture in so many updates, and most of the time they describe it as Kaposi sarcoma. I also came across text that said what you just highlighted, but I don't really know the reason, because initially when I was giving the different types, I even wrote HIV associated, but later I saw somewhere it wrote AIDS associated. So after saying in the text that irrespective of the CD4 count, they can still have Kaposi sarcoma. So why will you wait for it to be the CD4 count to be that very low before you now begin to say it's AIDS related, since it can occur at any stage? So honestly, maybe the infectious disease people will highlight more things on that. But I am thinking of Kaposi sarcoma as a differential diagnosis, as my diagnosis. But it's difficult to say that clinically. But maybe with the biopsy of any of the suspected lesion, either in this patient depicted or in the biopsy result that can really define what it is, either Kaposi sarcoma or bacillary angiomatosis. Thank you.
Okay, thank you so much, Dr. Musa. I think I agree with you, because even the P.PL, you didn't say what it means in full. It means person living with HIV. And Kaposi sarcoma can even occur in persons without HIV. So why won't it occur in people with HIV irrespective of the CD4 counts? So that's why you have the good prognosis and bad prognosis according to the 8 clinical trial group. So those with CD4 greater than 200 will fall into the class of those with good prognosis. So I think it can actually occur irrespective of the CD4 counts, and even in persons without HIV. That's the endemic type, according to the classification. All right, thank you so much. Okay, Dr. Ede, please go ahead. I saw your hand. You want to say something?
Thank you. Yes, thank you. Good morning. Thank you for the presentation. Apart from CD4 count, there are other prognostic factors like visceral involvement, like you mentioned, if the GI and other visceral do. Again, is another one is pulmonary involvement because they're at risk of pulmonary hemorrhage if the lungs are involved. Likewise, extensive cutaneous involvement or other mucosal involvement. Then the epidemic type, which is the HIV type 2, is a poor prognosis. All right, thank you.
Oh, thank you so much. Okay, let me comment on the chat. Dr. Musa, thank you for a nice presentation. I love that for you. Okay, but let me get to kind of say good morning. Thank you for the wonderful presentation. What are the histologic findings in bacillary angiomatosis that will help to differentiate both as similar as you said? Okay, can you reiterate that? I think you just mentioned it.
I mentioned it. I said the lesion in bacillary angiomatosis. Are you hearing me? Sorry, it's
I can hear you, Chief.
I said the lesion. I said the lesion in bacillary angiomatosis typically possess capillary proliferation and neutrophilic inflammation, in contrast to Kaposi sarcoma lesion that displays slit-like vascular spaces containing lymphoplasmacytic infiltrates. I said again that it's difficult. These two, the organism that causes bacillary angiomatosis, the Bartonella, Hensele, or Quintana, the Kaposi sarcoma, they all have predilection for the vascular endothelial cells, the macrophages, and then the vascular endothelial cells, the macrophage, and red blood cells. They induce the cutaneous angioproliferation. So by the time you see capillary proliferation and neutrophilic inflammation, you begin to think of bacillary angiomatosis. By the time you now see lymphoplasmacytic infiltrate, slit-like vascular spaces, then you begin to think of Kaposi sarcoma. Thank you.
Oh, thank you so much. Okay, so Dr. Logo is saying thanks. Dr. Adobe says thanks. Lovely presentation. Thank you. Can psychosis Babe be a differential?
Psychosis Babe, well, from the name Babe, involving the dead area, it's a possibility. Maybe the dermatologist will help us clarify, but I've not come across it. The common differentials that I saw besides this one I listed is, they say, cutaneous mycobacterial infection caused by Mycobacterium haemophilum. Then you can also have all these cystoplasm, all this fungal infection. You can have lymphoma in terms of the oral lesions. I've not come across that, but it's a possibility. I don't know. Maybe I need to check that, or the dermatologist in the house will help us clear it. You know, there are so many skin cutaneous manifestation that can be seen in somebody that have retroviral disease, either because of the HIV virus itself, or because of the opportunistic infection, or because of drug therapy. So there are so many, but I've not come across any of them, even in the usual cutaneous manifestation of retroviral disease. I've not come across that.
Okay, thank you so much. Although I stand to be corrected, but I saw that even fibroma. Okay, let me just add this so that you can correct me if I'm wrong. Dr. Linda, thank you. Okay, doctor, other differential like nevus, histiocytoma, cryptococcosis, leishmaniasis, angioma, pyogenic granuloma, and dermatophytosis could also be differentials. All right, Steve, go ahead.
Okay, thank you very much. So psychosis Babe may be the differential, like if it was only like more on the maybe just lateral parts of the face towards maybe the medial part. However, the nodules you would see there are not really nodular per se, but you'd see more of purples. Maybe if you'd say maybe a nodulocystic or nodular type of acne, then it will fit in more. And you know, for psychosis Babe, you would not find it like behind the ears as well. So that rules it out for you. And it's not that you said dermato something. I think you meant to say maybe dermatofibroma. All right, thank you.
Yeah, dermatofibroma is a differential too.
All right, thank you so much. Thank you so much, Dr. Sani, Dr. Justice, Dr. Leader, for the comments. Thank you for the questions, Dr. Laleko, Dr. David. Thanks everyone who said thanks on the chat. So in absence of any other comments or questions from the participants, I'll hand over to our teachers. Marcus Abel. Hello, ma.
Thank you.
Okay.
Okay,
I hear you now.
Your network is having hiccups, so thank you, Dr. Musa. Thank you, Dr. Bingpe, for helping us share. Thank you so much. Tekele, thank you so much. I appreciate the comments, the questions, and all. So thank you. I was wondering with the confusion, it was the confusion about the diagnosis. I think it was straightforward, by the way. It's the person that presented that tried to arrange the questions, trying to make it look get it towards Kaposi sarcoma. So there should not be any confusion if you see something like this in any of the exam, MRCP, whatever exam you're going for. Yes, MRCP and lab and whatever exam you need to go for. So once you see them, just a way, there's a person that was trying to ask the question, there's a scenario the person was trying to create. If you follow the person, I could always say common things occur commonly. Common things occur commonly. You can't see somebody with these characteristics. Okay, let's give an example. Like somebody has fever, somebody have headache, somebody have joint pains. In our environment, the first thing that will come to your mind is malaria. Other things will come on, but the first thing is malaria. So common things occur commonly. Don't try to create questions for yourself that, oh, this can be cholera, this can be typhoid. Common things occur commonly. When you start with the common things first, then you now move towards the ones that are quite uncommon. So that's so I must appreciate. So there's really no confusion. I must appreciate the presenter I did was quite lucid. I must also appreciate thank you, Dr. Linda, Dr. Ede, the dermatologist. Thank you for coming in. It made my job quite easy. Dr. Mustafa, I think he's an infectious disease specialist. Thank you too. Thank you. So just to add some few tips. I'm surprised Dr. Kalamama didn't say anything this morning. Dr. Kalamama, I hope you are fine. So yes. The other prognostic indices that I didn't mention is comorbidities. If this patient have other comorbidities, is diabetic, is hypertensive, has a chronic liver disease, all other comorbidities, definitely that's already a poor prognostic indices for him. Then also people that have drug resistance, people that have poor drug compliance, those ones are poor because we want you to have as much options as possible. Then also, people now they usually ask, how do you know that patients have systemic involvement? I think somebody mentioned multiple organ involvement is a poor prognostic factor, which is good. But how do you know if they usually ask this question? I think it's part 1, it was quite common then. Usually ask, how do you know if somebody has systemic involvement? Musa, I don't know if you came across such you came across anything like that.
How will you know that somebody has systemic involvement?
Yes.
Well, if the presence of the systemic symptoms, the fever now, when in the present, if you have this rash, then with underlying fever, unexplained fever, night sweat, greater than 10% involuntary weight loss, diarrhea persisting for more than 3 weeks, you suspect that this patient has a systemic symptoms, ma.
Okay, thank you so much. That was a fair attempt, but that's not the answer. Remember, these things you mentioned are seen people with the background diagnosis.
Yes, sir.
These are common symptoms. What you do that's one of the reasons dermatologists are always looking at their mouth. When no matter the extent of the lesion, we'll tell you, open your mouth, let's see. They're looking at the soft palate. Are there lesions there? Once there is a lesion in the soft palate, it shows systemic involvement, a poor prognostic factor. So that's just what I wanted to add. Overall, it was a wonderful attempt. Thank you so much once again. We appreciate you. I don't know if any of our facilitators have any questions, any comments, and then any add-on. Chief Cookie, Dahatu is in class, is an infectious disease specialist, Sanda, Success, Chitu, Remigus, Fatima, Okopi, Dr. Bansi. We have a full house. I don't know if any of our chiefs have any comments. Dr. Musa, I seem you impressed our chiefs. So thank you so much once again. Thank you. Thank you. We appreciate you. Thank you so much. Dr. Bigbe, thank you once again for sharing this slide.
Okay. Thank you very much.
You're welcome.
All right. Thank you so much, Ma. I think we can move on to the next. Dr. Ade.
Okay. Good morning. Good morning. I'm trying to share the screen. When I click share screen, it asks me to start recording or casting the Zoom. And when I say start now or cancel, then it goes off. Please, what do I do?
Click on start now. You can click on start now.
Okay, I have. Okay. It's not allowing me to share my screen, so I don't know.
You can send it to the group. Let someone help you share.
Yes, I'm doing that one. Thank you.
After the class, just reach out to me. Let's see what the problem is.
Okay. Thank you very much.
You're welcome.
So I have sent it to the group.
All right, thank you. Someone help us share, Dr. Wipe. Can I trouble you again?
Thank you, Dr. Binkwe, in advance.
Okay, Chief.
Okay. Thank you very much. Thank you. So, okay. So I'm Christian Adai. I like the way I get called Dr. Ade. It means that if I was Nigerian, that would be my name. I love it so much. I'm Christian Adai. Okay, so we can move on. Okay, so thank you very much. Good morning, our facilitators, senior colleagues and colleagues. I'm presenting practice question 5A. A young male presents with crash injury to the lower limbs following a road traffic accident. He was pale. Blood pressure was 86 on 52. Pulse rate was 124. Respiratory rate was 24. And the creatinine was 365 micromoles per liter. He reports passing dark-colored urine, and he has passed 20 mL of urine in the past 4 hours. No remarkable chest or abdominal findings. Questions. A, what is the diagnosis? B, what is the pathogenesis of the kidney injury? C, what will you find on urinalysis? And then D, what will happen to the serum potassium? E, mention 2 possible ECG findings due to the serum potassium levels. F, mention 3 other possible lab findings. And then G, discuss the principles of management. So the first question is, what is your diagnosis? My full diagnosis will be rhabdomyolysis with hypovolemic/distributive shock and pigment or myoglobin-associated acute kidney injury, likely stage 3. I'm saying likely stage 3 because of the urine output and the serum creatinine that we have been given. So that will be my full diagnosis for the answer to question A. And then B, what is the pathogenesis of the acute kidney injury? So there are 3 main pathogenic factors for the AKI in rhabdomyolysis. And these are 1, the intrarenal vasoconstriction from the prerenal hypoperfusion. And then 2 is direct renal tubular toxicity from myoglobin and its product ferrihemate. Please, can I be heard?
Yes, you can.
Okay, thank you very much. And then the third mechanism is the mechanical obstruction of the.
Go ahead, I can hear you.
Okay, so the third factor is the mechanical obstruction of the distal nephron lumen when myoglobin precipitates with the tam-horsfar protein. So let's look at the 3 mechanisms a bit more. So the first pathogenic factor, injury to the muscle fibers cause disruption and release of myoglobin into the circulation. So what happens is that there is sequestration of fluid into the damaged muscle cells, and this leads to volume depletion. So the effective circulating volume is reduced, and this will lead to a reduced renal blood flow. Subsequently, the renin-angiotensin-aldosterone system will be activated, and that will cause renal vasoconstriction, and this will lead to the prerenal azotemia. So this is the first pathogenic factor theory that has been postulated. Then another theory is that the myoglobin depletes nitric oxide, and we know nitric oxide is a vasodilator, and this would also lead to subsequent release of cytokines, eventually culminating in renal vasoconstriction. Then, next slide, please. The second factor is the direct renal tubular injury, and this is mediated by the heme that is released from the myoglobin. Like I said, the product of myoglobin breakdown is ferrihemate. And this substance has a higher affinity for oxygen than the hemoglobin and undergoes chemical reactions that eventuates in the formation of reactive oxygen species, which are responsible for lipid peroxidation of tubular cells. And this will ultimately lead to acute tubular necrosis. So this is the second factor. And then the third pathogenetic factor is that the excessive myoglobin that floods the serum as a result of the breakdown of the muscles will interact with the tam-horsfar proteins in the distal tubules, and this will result in cast formation. And as we know, once you form cast in the renal tubules, this will lead to tubular obstruction. And this process is facilitated in the presence of acidic urine. So we'll come to know shortly in the management why we will need to alkalinize the urine in order to reduce the formation of this cast from the myoglobin and tam-horsfar protein. Next, please. Okay, so what are the findings on urinalysis? So you would have a dark-colored urine, and some authorities also describe it as a tea-colored urine. Then one of the critical things you will note is that your dipstick is positive, and it's positive for blood. But when you do the microscopy, then you do not have red blood cells. So a combination of a positive dipstick for blood and negative RBCs on microscopy should always raise your suspicion of myoglobinuria from this process. Then you can also see pigmented casts. Like I said, the myoglobin combined with the tam-horsfar protein will cause this cast. And the renal tubular epithelial cells can also be found on urine microscopy. Next, please. Okay, so what will happen to the serum potassium? We know that potassium is an intracellular cation. So once you break down the muscles, the serum levels will be increased. So this will result in hyperkalemia. So it's one of the most severe complications of rhabdomyolysis. And then the next question is that what findings will you see on ECG in the setting of the hyperkalemia? So ECG findings of hyperkalemia, you would have a shortening of the QT interval. There will be peaked T waves, or what we normally call the tau tented T waves. The ST segment will be depressed. You may have widening of the QRS complexes. Then also the PR interval may be increased. And then subsequently, your P amplitude will even decrease or even disappear completely. And when it gets worse, you would eventually have a widening of the QRS, and then ultimately you would have a sine wave on the ECG. That will be the severe form. So this is just a pictorial representation, comparing hypokalemia at the top and then hyperkalemia at the bottom. So you see that for the top, the hypokalemia, the T wave is flattened, but down there for the hyperkalemia, you have a tau tented T wave. And then as you go along, the ST segment may be depressed for the hypokalemia, but the hyperkalemia, you see that there's a widening of the QRS complex, and then eventually the P wave is lost, and then ultimately you will see the sinusoidal wave. So that's just a pictorial representation of some of the changes that you would see. So it says mention 3 other possible lab findings. Okay, so because you have damaged the muscle fibers, all the intracellular substances and enzymes are released into the blood. So a measurement of the serum levels of all these substances would aid you in confirming your diagnosis. But one of the first things is the myoglobin. But one thing to note is that the plasma myoglobin is the first to increase, but it has a very short half-life. So within a matter of 24 hours, it returns to normal. So it's not a very good marker for confirmation. What it means is that if you do this and it is negative, you may falsely rule out rhabdomyolysis. So we prefer the urine myoglobin because that one has a long half-life, and then you'll be able to pick it up. And especially in the setting of a coexistent hematuria. You know, I said that when you see positive dipstick, blood dipstick, but negative RBCs, you should suspect rhabdomyolysis. But if the patient already also has some blood in the urine, you may be confused, but the myoglobin will settle the matter for you. And then also the creatinine kinase is actually the most sensitive, and it is the gold standard. So an elevated creatinine kinase actually clinches the diagnosis for you. And when the serum level is very high, especially above 15,000 units per liter, it is predictive of renal failure. And in fact, AKI is the most serious complication of rhabdomyolysis, as has occurred in this patient. Then you can also do APTT and then PT-INR. So you may have thromboblastin released from the injured myocytes, and this can cause disseminated intravascular coagulation, leading to a prolonged INR APTT. Then your calcium levels, it may be low initially, but eventually, because it is released into the circulation, you have high levels, as well as the uric acid and phosphate. They are usually increased. Your full blood count may also show a low HB, and then the platelets may also be reduced. Serum aldolase is also raised, lactate dehydrogenase is raised, and your LFTs, you may see elevated AST. Next, please. So these are what are the principles of management? This is the last part of the question. So I will go into the details, but I will leave the details for the presentation for us to read. I'll focus more on the principles. So the principle, first, this is a multidisciplinary team approach that you should adopt. You may need a nephrologist. This patient has stage 3 AKI, most likely may require dialysis. You need your emergency room physicians. This guy was involved in an RTA. He might have sustained a fracture over there. The orthopedic surgeons may come in because of the possibility of fracture or a compartment syndrome as one of the complications of rhabdomyolysis. You may need hematologists and several other people based on the presentation. Then your ABC is very important. This guy was involved in an RTA. You make sure that your airway is patent, the patient is breathing, you secure your IV access for adequate fluid resuscitation. Because in fact, the mainstay of therapy for this patient is adequate and aggressive fluid resuscitation. You really need to give a lot of fluids. Then you have to treat whatever the underlying causes. We will come briefly to know the causes, but we need to really identify the causes too and deal with them. And especially too, if there are also complications like the AKI compartment syndrome, DIC, you deal with that. What would help you is the serial physical examination and then the lab studies. You need to correct the hyperkalemia. This patient already has hyperkalemia, and if there are any other imbalances present, you also correct them. You need to do a forced diuresis after you have adequately hydrated the patient. It's very important. Adequate hydration, and then afterwards, you can do forced diuresis with mannitol and then furosemide. Even though some authorities say that this is controversial, but majority of them agree that you should do this. And then, as I said earlier on, the acidic urine helps with the cast formation by allowing the thymophosphate to combine with the myoglobin. And so alkalinization of the urine is also a very important principle of management. Next, please. So like I said, the fluid resuscitation is the cornerstone of the treatment, but the details, for the sake of time, I will leave the details for us to look at in the slides. And then if, like I said, your creatinine kinase is more than 15,000, it predicts acute kidney injury. And you may have to give a lot of fluid for such patients, up to about 6 liters. You remember from the pathophysiology, pre-renal hypoperfusion to the kidneys is one of the main things. So you must really adequately hydrate them. And then the fluid will also help you to get rid of all the cast that is causing the renal tubular obstruction. And then if your patient has cardiac disease or renal disease, you may consider using a central line or a swan gas catheter to monitor them. And then you must repeat your creatinine kinase assays quite frequently. But like I said, in our environment, we need to be practical. They are saying every 6 hours. Some say even every 2 to 4 hours. But at least if you do it daily, I think it should be sufficient for our environment. Next slide, please. So the urinary alkalinization, as I said, is very important to help you prevent or reduce the amount of cast formation. So you would use sodium bicarbonate to do this. And whilst using sodium bicarbonate, you may also cause hypocalcemia. But like I said, eventually, because of the damage to all the myocytes or most of the myocytes, calcium will be released into the circulation. So you shouldn't worry initially about that. But if they develop signs or suggestive of hypocalcemia like seizures and tetany and all that, you should replace it. Your aim is to ensure that you get a urine pH which is more than 6.5 with the use of these bicarbonates so that you can alkalinize the urine. So next slide, please. And then for the forced diuresis, after you have adequately hydrated the patient, I need to emphasize that. Adequate hydration, then you can do your forced diuresis with mannitol at the rate that is stated. And then also, if you can add the furosemide, depending on how adequately your urine output is. You will actually aim for a urine output of about 200 mL per hour. If there are other electrolyte disturbances, you can correct them as appropriate. Next slide, please. Okay, so dialysis may be necessary, especially in this patient that I suspect has a stage 3 CKD. If you do all your medical therapy and you are still not achieving control, or if the patient has congestive heart failure or persistent metabolic acidosis or pulmonary edema, then you may have to use dialysis to deal with the matter. Use of antioxidants have been advocated, but their clinical use remains unclear and there is not a lot of evidence to support them. And then fasciotomy, which is one of the complications that can occur, as well as fractures in this patient who was involved in an RTA, may require the need for surgical consult, especially orthopedic. Because if there's compartment syndrome and you do not release it, you would have muscle necrosis, and that can worsen the kidney problem as well as the other complications. If a patient develops DIC, which is one of the complications, you may use fresh frozen plasma, cryoprecipitate, and platelet transfusions. Next, please. Okay, so that is it for the answering of the question. But just some few slides. Maybe I won't go into details. As we look at them, we can get these things. So briefly, the causes of rhabdomyolysis. Hello.
Okay, yes. Just 1 minute, because the time is up.
Sure. So these are some of the causes of rhabdomyolysis, apart from the trauma that led to our patient's scenario. So you can look at them. Next one, please. Okay, so the pathogenesis, I've already said the pathogenesis for the kidney injury, but generally the pathogenesis for the muscle issue. When there is damage of the muscle fibers, all the substances that are intracellular are released into circulation, as you could tell from the investigations and the things that we did. And then one of the main problems too is that these processes that move ions across the membrane require ATP. So if there is depletion of the ATP, all these pumps will fail, and then all the disturbances that we saw would occur. So that's basically what happens in the pathogenesis of the rhabdomyolysis. So let's go to the next slides. I think next. So this is a summary of all that I said in the management. So all that I said in the management, if you look at this algorithm, you would appreciate all that I have said, summarized in this one page. And then the last slide, I think, is the complications. We can just look at the last slide. So these are the complications of rhabdomyolysis. AKI is the most serious. Then they can develop compartment syndrome. You have hypovolemia from the sequestration of fluid into the muscles. You notice that this patient was actually in shock, even though there was no external bleeding or even a suspected internal bleeding. There may be internal bleeding, but generally it's because of the sequestration of the fluid into the damaged muscles that leads to the hypovolemia, effectively reducing the circulation and causing the perirenal hypoperfusion. And then you can have early hypocalcemia, and then subsequently, when all the pumps fail, then there's efflux of calcium into the serum, and then you develop hypercalcemia. Hyperkalemia is also a complication. Hyperphosphatemia is also a complication. And then the disseminated intravascular coagulopathy is also a complication. So I think that brings us to the end of it. These are my references. Thank you very much.
Oh, thank you so much, Dr. Adai, for that beautiful presentation. I hope I got it right this time. Thank you so much. Okay, so let's give it thanks comment in the chat. And then if you have a comment or a question, you can raise your electronic hands, or you can drop your comments on the chat. Okay, I can't see any hands up yet and no comments. So it's obviously a very beautiful presentation. Okay, please let me just ask this question. In the pathophysiology, that part where the myoglobin precipitates with Horsfall protein and causes a tubular obstruction, would you call that post-renal or intrinsic AKI?
Okay, I think that aspect will be post-renal.
Okay. Thank you. Okay, I don't know if I have more questions and comments. It was a very beautiful presentation. Okay, I was also wondering, because one of the questions was about the potassium. If you could maybe just add the management of the hyperkalemia to the slide, that would be nice.
Oh, okay. Yes, I agree. I think it is in the management, but because okay. I wanted to skip for the sake of time. It's in the management. You would use IV glucose and then insulin to push the potassium back into the cells. And then if there's acidosis associated, you use your sodium bicarbonate. Eventually, like I said, if it's persistent or you are not able to correct it medically, then you would get the nephrologist involved for the dialysis. Thank you.
Well, thank you so much. Okay, Dr. Aminu Bashir, go ahead, please.
Okay. Good morning, everyone. Good morning. Good morning. Your name sounds like cool guys. Well, it was a wonderful and lucid presentation. It's a very great one. Eloquent. It's just on the controversial aspect that you mentioned, the issue of post-dialysis. Just as you said, it's highly controversial. And I wouldn't know if it's something of such controversy because so many of those I know, they are of the opinion that you should just gives zealous hydration of the patient, and it's expected that the patient is going to diurese. While you are doing the zealous diuresis and zealous hydration of the patient, you try and, just as you mentioned, the central line catheterization so that you don't overload the patient. You monitor the prior so that you're not overloading this patient. So I know definitely you got a source that is for. They are pro diuresis, and there are some that are of the opinion that you don't need it, that it's
Am I the only one not hearing?
No, I'm
Can
also
you
not.
hear him?
No, I can't hear him. I think he's falling off.
Okay, Dr. Bashir, I think we lost you. Okay, so a lot of thanks to you, Dr. Adai, on the platform, from Dr. May, Dr. Shamsuddin, Dr. Rita, a lot of thanks. And then Dr. Florence Briggs says, can your diagnosis be arranged as AKI secondary to rhabdomyolysis, complicated but with hypovolemic shock? And then Dr. Ida is saying, thank you. Can the diagnosis be simplified? AKI secondary to rhabdomyolysis and shock. Dr. Christian, you want to make a comment on that?
Oh, sure. In fact, yes, I actually even decided to leave it like this and then see what the class is, because generally we can just say that. I can't hear you again. Oh, hello. Can you hear me now?
We can hear you.
Okay. So I would have simply said that rhabdomyolysis with AKI, or rhabdomyolysis complicated with AKI, and just leave it at that. But because they gave all those values, the blood pressure, I think was 84/50 or something, with a pulse of 124, a respiratory rate of 24, urine output for the past 4 hours of 20 mils or so. So I thought that I should just capture the fact that the patient was also in shock. So I think we can decide how to rearrange it. Once all those things are captured, I think that is fine. So I agree with the comment.
Hello, yeah, good morning. This is Dr. Shito. I think you said it correctly already.
Okay.
Yeah, some people would say put AKI first, but AKI is the complication, not the diagnosis. The diagnosis here is rhabdomyolysis. The complication is both the shock and the AKI. So rhabdomyolysis complicated by the hypovolemic shock.
All right, thank you so much, sir.
The acute kidney injury.
Thank you very much, Dr. Shito.
All right, thank you so much, sir. Okay, so Dr. Blessing is asking, please, apart from Banitol, can any other diuretic agent be used? Dr. Adai, can you hear me?
Yes, I can hear you. Okay, thank you. In fact, these are the two that I came across, mannitol and furosemide. But like Dr. Aminu Bashir was saying before, I think he fell off. Even the use of forced diuresis is quite controversial. Not all the authorities agree. But for those who are for the forced diuresis, these are the two agents that I came across in all my reading, mannitol and then furosemide. I didn't come across any other one. Thank you.
All right, thank you so much. Dr. Wasinda, I agree with you. Thank you so much for the wonderful presentation. Loop diuretics acidify the urine, so mannitol is preferred if you must do forced diuresis. Thank you, Dr. Wasinda.
Okay, thank you.
Okay, so I can't see any other electronic hands raised, Dr. Adai. Thank you so much for the beautiful presentation. So I'll hand over to our teachers. Crystal.
Oh, thank you, Dr. Ekele. Thank you so much. Thank you. Dr. Chris, thank you so much. That was wonderful. From the attitude you were already showing the class, I didn't expect anything less. Since you joined, you promised to be active and you kept to your word. So thank you for being so wonderful. I appreciate your presentation and the time you used in preparing for it. Chief Chitu, Chief Remy goes straight to I'm calling on you guys. This is the random question so that we just talk about it. Chief Chitu, sir, go ahead.
So that we just it's almost 8 o'clock already. Yes.
Yes.
Well done. He actually spoke very well. I like the way he went about the pathophysiology pointing out that it's a multifactorial, a pre-renal component, you have an intrinsic component, and you have a post-renal component. It's one of those few diseases that would give you all three at once. Okay? It's important to note that, yes, we do force diuresis, but it's not, well, you try and avoid that. Many a times, if the person is not making urine, just dialyze the person. Once the person remains oliguric, despite all the things you're doing for the person and the creatinine is still rising and he has met criteria for hemodialysis, then you rather do that. Okay, because fusimide in itself is nephrotoxic and could worsen the chance of forming uric acid stones, which is the main reason why you're alkalizing urine in the first place, because you don't want uric acid stones to form. Okay. Then when he was talking about when to call the nephrologist, please, you call the nephrologist from the beginning. Okay. AKI is like the commonest complication following a rhabdomyolysis. And you don't wait to when you need dialysis before you call the nephrologist. You call them as early as possible. If they can prevent the patient going on hemodialysis, then that is better. But just to point out that the hallmark or the principles of management of these patients include: 1, to resuscitate the patient; 2, vigorous fluid resuscitation, okay, because that is the mainstay. That is what will push out whatever it is, right? And then, of course, dealing with electrolyte imbalances, and ultimately, if the person meets criteria for it, then you can consider hemodialysis or any other form of kidney replacement therapy. Okay, so I think he spoke very well, and I will commend him and say well done.
Thank you, sir. Thank you so much, sir.
Thank you very much.
Hello.
Chief Ramugu, sir, go ahead.
Yeah, thank you. Thank you, Chief Shitsu, for summarizing the thing. When Chris Ade was talking, I was convinced he's a nephrologist. Are you a nephrologist?
I am an endocrinologist.
Wow. Okay. You did an excellent job. In fact, there's really nothing much to add. I just want to wade in a little on the issue of diuresis. Almost all nephrologists frown at diuresis as a treatment for AKI, okay? No matter the form of the AKI, because studies have shown that in fact, in some situations, it is detrimental, okay? There's no study that showed an added benefit, okay? However, the teaching has always been, if there's fluid overload, please do not hesitate to give diuresis, all right? So, and that's why sometimes it's important to do central venous monitoring. So sometimes the patient can even be patient can enter polyuric phase. Do you want to be giving diuresis when someone is already in polyuric phase of AKI? What's the essence? Okay, so the patient is what matters. You manage according to the patient in front of you. Has the patient become fluid overloaded? Why not give your fluid, all right? Okay, so give your diuretics. But if the patient is not fluid overloaded, there's no need. And please, when you're talking about management, never forget hyperkalemia for reason for dialysis. All those other measures, like pushing potassium into the cell, they're just temporary. They don't do much. Okay? Even the use of diuretics, it doesn't really do much. Dialysis is the way to take out the potassium, especially when it becomes troublesome. So yeah, you can mention all those ones while you are waiting to do dialysis for the patient. Okay. So I think these are the things I wanted to add. By and large, you did a very beautiful job. I loved your pathophysiology, everything, the way you set out. Your diagnosis was awesome. You captured the main things. There's no way someone will be in shock and will not capture it in your diagnosis. You never do that, because those are the most important things. It might even be the shock that is causing the AKI. So you have to take care of it. So you must mention it in your diagnosis. Thank you.